Good afternoon. I'm Carla Loeppky. I'm the Director of Epidemiology and Surveillance with the province of Manitoba. I'm going to quickly go through some of the statistics relating to active tuberculosis surveillance in our province. So when Ron and Boaz were talking about their TB journey, you were talking about it from a personal clinical perspective, but everything that your doctors were collecting was entering into the surveillance system. So all of these spots and arrows are marking the journey that you are on, but also the journey that your data goes on. Tuberculosis registries across Canada are in depth, they're historical, and they contain a vast amount of information that can provide us an understanding of what's going on. Now remember too that surveillance isn't going to answer questions about why is this happening or what's the cause of the issue, but it is going to provide us a good understanding of what the trends are over time and if there's different populations that are impacted. So one of the things that in one of the WRHA epidemiologists provided me with was it's called a Health Inequalities Data Tool provided by the Government of Canada. I wanted to put it up here because it was one of the resources that I used to collect information on TB. This is available to everybody, and it should be and might be something that you want to look into. You can select what you want on the side to get the information and the breakdowns accordingly. So from this, I was able to look at the active tuberculosis disease over the course of all of the provinces as well as Canada in total. And you can see that the prairie provinces, Saskatchewan and Manitoba, have high numbers. And if you would convert these to rates, you would see that they're disproportionate compared to the rest of Canada. If you look at, I was providing information specific to Manitoba. These are case counts, okay? So this is just the number of active TB cases. So when you're looking at this and you think, well, we've just got a little orange, Boas's favorite color, little orange blocks. So clearly it's not really an issue compared to the overall number of TB cases in Canada over time. And shortly I'll convert it into a rate so that you can see what that looks like. And then when you look at the groups that are most impacted, you can see, and I'll slip to the next slide so that you can see a variation in the types. You can see that in Canada, Canadian-born Inuit have the highest rates, whereas in Manitoba, Canadian-born First Nations have the highest rates. The picture across Canada is not the same. Now back to Manitoba, you can see the blue line that's going down is the rate of active tuberculosis across Canada. It's going down, but in Manitoba, you can see that it's fluctuating, but on the whole, the trend line is going up. Our experience in Manitoba, and I would spread it to the prairie provinces, is much different than what is happening throughout the remainder of the country. I don't want to spend a lot of time because I think that the reason we're here is to hear what's happening in the north, but I do want you to know about those different tools that are available in different areas. The province has put out a little while ago a document relating to distribution of LTBI and completion rates of treatment relating to the WRHA. There's also other documentation that you can access that guides your understanding of what's happening, the trends over time. In the next little while, in June, I believe, there will be a Manitoba Centre of Health Policy report put out relating to tuberculosis in the province as well. Will be a critical document as we move forward. So keep your eyes out for those resources and understand that the trends that we experience here in Manitoba are different than elsewhere in the country.
Hello, everyone. I'm Brent Roussin, Medical Officer of Health here in Manitoba for First Nations Inuit Health Branch. And I'd like to start by acknowledging that we're meeting here today, and I live and work on the original lands of Treaty 1 people and the homeland of Métis people. And thanks to our guests, our elders, and thanks to our guests who discuss their TB journey. People like myself who live with privilege have a lot to learn, and we need to listen more to these kind of stories. So I'd like to just discuss the overall strategy that Manitoba region is taking with TB, more high level, and focusing on some of the newer initiatives that we really hope can help us turn the corner with TB in Manitoba. So we focus our plans on our high incidence communities. We have 14 of them, and we'll get into the definition and some of the incidence rates that we see with that. But really the focus of our strategy is community engagement. And we need to focus more at that community level, increasing capacity, increasing the community's involvement with our plans. And one of the newest features of our program is the community champions. And so we're working with communities to hire individuals of their choice. We'll provide the biomedical training, the support to them, but we really want to work with them and the communities to try to get that knowledge back to the community on what's the best approach for the people of that community. How can we provide support? How can we best engage with them? So we are moving forward within the next month with that community champion program, and we're looking to have 4 community champions in our highest incidence communities within the next month or so. So we're really looking forward to that contribution. One of the issues that we see, and we heard Boaz speak very eloquently of it, is the issue of stigma. And that's something that we're hoping the community champions can help us with. Address and improve over time. We've really continued to collaborate with a lot of partners. We work with the WRHA. We have a large agreement with the Winnipeg Regional Health Authority to engage in case management and contact tracing. Most of the clinical work is done by clinicians within the WRHA. We work with the Northern Health Region, again with case management, as well as some clinical work, but the NRHA has really stepped up with helping us in community for surge capacity, bringing public health nurses to our remote communities, helping us work on contact lists, and has been very supportive and very helpful to us. And one of the newest collaborations is with the Public Health Agency of Canada and the National Micro Lab, where we are looking to get rapid testing for TB into our communities. And we're really hoping that will help us turn the corner on a number of our communities. And the rapid testing is going to be available next month in one community. And then in April, very likely all communities are going to have access to the rapid testing. So despite the high numbers in Manitoba, we noticed a number of missed opportunities that clients were presenting to care with symptoms of TB, but because of the many issues going on, we missed the opportunity to diagnose TB. So in 2016, we initiated active case finding in each of our high incidence communities, meaning everyone presenting to the nursing station was going to be screened for the signs and symptoms of TB. Regardless of the reason for presenting, we're going to screen for the signs and symptoms of TB. If they hit on any of those signs or symptoms, we're going to obtain sputum collection. Now that sputum collection is going to include the rapid testing very shortly. So we're really hoping to be able to diagnose much earlier, get that person in treatment much earlier, get working on that contact list that much earlier, and moving forward through the outbreak. And I'll demonstrate this later with an epi curve we have prepared. LTBI, latent tuberculosis or sleeping TB. Really the medical driver behind the outbreaks in Manitoba. Every outbreak that I've been involved with has begun with a reactivation of a client known to have LTBI. So we can imagine any outbreak is going to start with reactivation, but in our communities, it's somebody that we knew had LTBI. So we weren't able to provide treatment, we weren't able to complete the treatment, and later on reactivated, and we're in an outbreak situation. So typically, up to now, with the LTBI burden, we've been able to treat roughly about 30% of newly diagnosed LTBIs. The treatment is twice a week for 9 months, very onerous, people who feel completely well and already have enough on their plate. So it's very tough to get these treated. But with recent changes, we are able to obtain rifampicin, which is a relatively new medication in Canada. And so instead of treating twice a week for 9 months, this is once a week for 12 weeks. Just as safe, just as effective as the original treatment. And so we were able to use this and pilot it in one of our remote communities. And from that community, we were able to get 80% uptake and 80% completion of LTBI. So you can see that we, with the work of the community and everyone involved, likely prevented that next outbreak that's going to occur there in a couple years. That normally happens. So we're really looking forward to using this rifampicin, which is going to be available in all of our communities, and it is currently now prescribed in any of our high incidence communities. So we're really hoping to get a handle on that LTBI burden. On the subject of LTBI still, like I said, we are not going to be able to reach everyone with LTBI, and we know that those missed opportunities are leading to future outbreaks. So we really want to support people who are unable to start or complete their treatment with LTBI. So we're going to be offering screening, symptom assessment every 3 months, offering chest x-ray every 6 months, that those small group of people, hopefully going forward, that aren't able to take LTBI treatment, we are going to catch them very early on in their disease course before it's going to adversely affect their health or be very infectious to other peoples in the community. So that's sort of the overview of some of the new interventions that we're trying. We heard of the overall Manitoba number, some more numbers specific to our First Nation on reserve category. We'll see that over the last many years, we're about 60 or 70 active cases per year. In 2016, for reasons unknown, we had a very high number, over 100. But we see last year it's come back down to our baseline, and we're hoping with some of these new interventions, we're really going to turn the corner next year and start seeing these numbers come down to something that we can build on. This is a definition of the high incidence communities. This is just how we punch in those numbers to determine which communities end up being high incidence. If we break down the communities, the 14 high incidence communities, and look at the incidence rates, we can see really the inequity that TB presents. We'll see these communities here, 600 per 100,000, right? Where Canada's is 5, we've heard. So you can really see the impact this has on communities and the urgency that we need to address these measures. And I'm going to end with this slide. This is an epidemiologic curve. This is how we map out our response to an outbreak in TB. And this shows us quite a typical TB outbreak in a remote isolated community. It can demonstrate some of the challenges that we're facing, and it can also give us a glimmer of success in this community and moving forward. So you can see that the first 2 bars there, the blue bars, represent people who are smear positive. Those are people who are typically very sick and very infectious. So they present for care, they're diagnosed and treated, and then we mobilize. We actively case find, searching for other cases, searching for contacts, testing as many people for TB, and then we start seeing the red bars there, the smear negative, people who only culture the bug growing after many weeks. Not as sick, not as infectious. And you can see that those culture positives, the red bars, are very spread out. And that's because the nature of TB is very slow growing. So those are people who are taking sometimes 4, sometimes more weeks more than 4 weeks to diagnose. With the rapid testing, it's going to take 2 hours to diagnose those individuals. So we're going to hopefully bring that curve much together and start on the contact list, start getting those people in treatment, and we'll see that we'll be able to bring those outbreaks to a close even quicker than this one. But you could see as far as an outbreak investigation goes, this took a very predictable pattern. Caught the sick cases, searched for the less sick cases, shut the outbreak down. We were able to use rifapentin in this community, 80% of LTBI treated effectively. So you might look at this curve and say, well, why do you still have so much TB if you're effectively shutting down these outbreaks? And the reason is that by the time this outbreak is done, there's 2 other communities that are had somebody reactivate with their LTBI. 2 unrelated outbreaks started in the same time as we shut this one down. And then they were off to the next community. So you can really see how that LTBI burden is slowing our progress, and we need to work on that. But with rifapentin, we're really hoping we can turn the corner on that. And so I'll just close to say that this is the biomedical approach to TB. All right, all of these approaches, they're new, they're innovated, but they're almost meaningless next to the importance of the social determinants of health. Right, we're not really going to address TB unless we can come together and address the living conditions, address racism, address all of the determinants of health that adversely affect the Indigenous people. So I'll leave it there, and I guess there's questions later.
Hi everyone, my name is Josiane Nast. I am a public health nurse and I'm the TB program coordinator for the Northern Health Region. So I'm here to tell you about our program and what we do. So the Northern Region is geographically the largest of 5 Manitoba regional health authorities. We're larger than Germany in land size, so 396,000 kilometers squared, but with total population numbers similar to Prince George, BC, about 76,000. We've got about 70% of our population being Indigenous. So we have 2 cities, 6 towns, and over 25 communities. So we have an identity crisis jurisdictionally because many different organizations are providing health services. So with Thompson being the hub of the north, it has the main hospital for receiving and treating people affected by TB disease locally and from various surrounding communities in the north. So Thompson is also where our program is situated, although we do provide services to the entire region. So what are the key roles and responsibilities of our program? So we facilitate medical management of all TB cases and contacts. We create links between the clients, the communities, and the healthcare providers. Also, the WRHA and First Nations Inuit Health Branch TB program staff with effective communication processes. So I spend a lot of time making phone calls and emails to various people around the province. And we provide appropriate referral networks for screening, early diagnosis, treatment, and care. And then we contribute to the monitoring system that includes regional and provincial data on TB. So one of our main duties is case management of all clients diagnosed with TB. So this is from the time of diagnosis until treatment completion. So it includes inpatient care, which involves education, a care plan, review of symptoms, review of medication side effects, discharge planning, and contact investigation. It also includes outpatient care, so we supply directly observed therapy, review of symptoms and side effects, frequent follow-ups for specimen collection, diagnostics and clinic appointments, so we do the booking of appointments, we provide requisitions, and we also help with transportation if needed. Ongoing education and encouragement, so we do use incentives quite a bit, which I'll touch on a bit later, and contact screening, so we complete screening of all contacts and we will initiate LTBI treatment. So with TB treatment being quite a lengthy process, we're always looking at about 6 months and up for TB disease. One of the biggest challenges that we face with our clients is achieving completion of TB treatment. So it's important to point out that successful completion of treatment of active and latent TB is not consistently associated with age, gender, or race. Adherence is a task-specific behavior, not a personality trait. And barriers to success derive from a complex interaction between the health system, personal factors, and social factors. So what do we do as a program to facilitate successful completion? So the most important is that the client is a priority. Flexibility, so we make ourselves readily available to see clients at all times. That is most convenient to them. We have close and regular communication with WRHA and First Nations Inuit Health Branch TB team, the HSC TB staff, and the physicians. So because there are often several different healthcare professionals involved with the care of a client, it could be all over the province. So the communication piece is all about the entire healthcare team knowing what's happening with the client at all times so that we're always on the same page. So we make a point to make clear and concise instructions and plan of care for the client prior to discharge from hospital. So the patient is often hospitalized for 2 weeks or more. So it gives us a lot of time to sit down with the patient, do the education, give them lots of time to ask questions, express concerns, and so they are always well aware of what's going to happen once they leave the hospital. So communication is key, as well as building relationships with the clients. So by demonstrating empathy and understanding, having a casual approach, positive body language techniques, while maintaining professionalism, so that can go a long way as well. We also have the option for linkage with our Indigenous health liaison worker in the hospital, and expressing to the clients the importance of successful completion of treatment and acknowledging their success when they're doing well. Also, outreach within the community to locate clients with housing instability. We perform tests such as sputum collection. We will do TSTs and blood work in the community as a last resort if the client has missed opportunities to see us at the office. So this is something we do fairly often. We'll just pack up our supplies and we go out and do it all over the community and get our testing done. We encourage and facilitate entry to addictions treatment programs for clients with addictions. So we do have a facility right in Thompson, which has come into play a few times in the past. We also offer incentives and enablers, so we have gift cards, taxi slips, and we provide snacks and bottled water. So we're lucky that we are able to offer care closer to home. So having an internist in Thompson with TB expertise for our adult clients, and also a collaboration between our local pediatric team and the pediatric TB experts in Winnipeg. We are expanding use of the new drug rifapentin for latent TB. It's a faster and easier treatment with higher rates of success, so completion of treatment. And we also have a fairly large team of DOT workers. So they are often nursing students, and it's not a necessity, but it's been a very valuable thing for us. So they go out into the community and provide treatment to our clients. And we also have an MOH who is readily available for phone conversations and in-person visits with clients who are not achieving successful treatment. That's everything.